To everyone. I'm Shwastika, the assigned moderator from DentalNet, and it is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, DentalNet. DentalNet is a dedicated all-in-one medical content platform designed exclusively for dental professionals. Our mission is to empower dentists, hygienists, dental specialists, and students with cutting-edge evidence-based knowledge to elevate patient care and foster ongoing professional growth. At DentalNet, we bring together a nationwide network of dental experts to share their knowledge, clinical experience, and practical wisdom. DentalNet is honored to be associated as a digital partner for this esteemed event organized by Indian Dental Association Hisar. We are truly delighted to collaborate with such respected professional body and to contribute the success of this academic initiative. The topic for today's session is unlocking the potential of CBCT in dentistry. Now, it is my great privilege and honor to extend a warm welcome to introduce our esteemed speaker and distinguished panelists for today's session. We are deeply honored to have with us our keynote speaker, Dr. Deepika Keshari ma'am. An eminent academician and clinician in the field of oral medicine and radiology, she holds a Master of Dental Surgery (MDS) and is currently serving as the assistant professor at a reputed dental college in Azamgarh. In addition to her academic contributions, she is a director and consultant oral and maxillofacial radiologist at Diagnodent Imaging Center, Pandepur, Varanasi. Dr. Keshari has consistently demonstrated excellence in both teaching and clinical practice, and her dedication to advancing diagnostic imaging has significantly contributed to improve patient care. Her depth of knowledge and commitment to her field make her a highly respected voice in oral radiology. And we are equally privileged to be joined by our distinguished panelist, Dr. Bhuvan Nagpal sir. A renowned expert with an exceptional and diverse academic background, he holds numerous qualifications including BDS, MDS, PGD, MSc, MBA, PGD, MLS, LLB, CCOMS, and PhD, FPA USA, reflecting his multidisciplinary expertise and commitment to continuous learning. Dr. Nagpal serves as a Joint Secretary of the IA Path branch and is a senior oral pathologist and clinical biochemist. He is also the founder president of POPMA Hisar. With his vast experience spanning pathology, biochemistry, and healthcare leadership, Dr. Nagpal brings a comprehensive and insightful perspective to today's discussion. His contributions to research, education, and professional development have been widely recognized and appreciated. So, without any much further ado, I would like to invite Dr. Bhuvan sir to take over. Over to you, sir.
Yes, good afternoon, everyone, and thank you, Swastika, for providing this opportunity. Respected, esteemed office bearers of IDA Hisar branch, distinguished speaker, dear colleagues, and participants. On behalf of Indian Dental Association Hisar branch, I extend a warm welcome to all of you to today's webinar on unlocking the potential of CBCT in dentistry. In recent years, CBCT, which is cone beam computed tomography, has revolutionized dental diagnostics by providing precise three-dimensional imaging, significantly enhancing our ability to diagnose, plan, and deliver treatment with greater accuracy and predictability. From implantology to endodontics, orthodontics to oral pathology, CBCT has become an indispensable tool in modern dental practice. We are truly privileged to have with us our esteemed speaker, Dr. Deepika Keshari ma'am, a distinguished oral and maxillofacial radiologist who will be sharing her valuable insights and clinical expertise on this important topic. I am confident that her session will enrich our understanding and help us integrate CBCT more effectively into our daily practice. At IDA Hisar, we remain committed to continuous academic growth, clinical excellence, and keeping our members updated with evolving technologies and evidence based practices. With this, I welcome you all once again and encourage everyone to actively participate, engage, and make the most of this academic session. Thank you. Over to you, Dr. Deepika.
Uh, एक slide
Yeah, please share this.
चल रहा है. Uh, can you see? Can you see my screen?
Yes, yes, yes. Your screen is visible.
Very
Yeah.
good afternoon to all of you. First of all, I want to thank Dr. Bhuvan and IDA Hisar for inviting me for this session. We'll be discussing about unlocking the potential of CBCT in dentistry. So, the technology is advancing. Similarly, the dental field has also seen many advancements. As you can see here, how dentistry was being practiced in olden times and to the current modern day dentistry. In a similar fashion, dental radiology has also advanced from old age dental X-ray machines to the latest CBCT machines. So, what I want to say is that change is the only constant in life, and one's ability to adapt to those changes will determine your success in life. I hope I'm audible to everybody. If there is any doubt or if there is any issue, please let me know.
Yeah, you are very much audible, Doctor.
Okay, okay. So, as you can see on this screen, that this is a circle, isn't it? Now, this picture we are seeing in 2 dimensions. Now, this circle can be a part of many structures. For example, it could be a part of a cone or a sphere or a hemisphere or a cylinder. So, that means we have to think in all the dimensions, and this also uh, applies to our regular dental practice, and it will be helpful in diagnosis. So, now the question is, why do we need 3D imaging? So the key drivers include increased demand for superior diagnosis and treatment, need for more reliable diagnostic tool, true anatomical details, distortion-free images, faster, better decision and treatment recommendation, predictability in surgery, better treatment plan, increased treatment acceptance, increased productivity and profitability, and excellence in dentistry. So before we proceed, let us have a look at this image. So as you can see here in 2D imaging, all the structures are getting overlapped. So we cannot study each and every pane or slice accurately. Whereas in case of 3D, we can study it like a book. As you can see that we can separate different sections and we can go and study at that level. So it becomes more accurate. That's the advantage of 3D imaging. So as we go further, let us first discuss about the different body planes in which we study any CT scan or a CBCT scan. So you can see that this is the axial or a horizontal plane or transverse plane. This one is the coronal or the frontal plane, means you go from front to back. And then this one is the sagittal plane. Sagittal means you go from right to left. Okay. So in these sections, you will study a particular scan. Let us go ahead and discuss the difference between a CT scan and a CBCT scan. So what happens in CT scan, as you can see in this image, the beam is in form of a fan, whereas in CBCT it is in form of a cone. So fan means what it is doing is that it is moving around the object and it is making multiple images, and then it is clubbing all those images, stacking them together, and it is forming one image. Whereas in cone beam CT, it is entire volumetric analysis. So what happens in this? It will go around the patient only once, and then a final image will be obtained. Now, what is the advantage of this? So in this, since it is acquiring the entire volume. So what happens in this? the axial, coronal, and sagittal, all the images will be true images. Whereas in case of CT, only axial images, like this one, the transverse plane, only this one is real image and other ones are virtual images. So how do we understand this further and why it is required? As you can see here in CBCT, you can see this voxel. The image is acquired in the form of a voxel. So what happens here, you can see that this is in the form of cube, whereas this one is in the form of a cuboid. So in the form of cube, you can see all the planes are equal or all the sides are equal. So when we are going for a multiplanar reconstruction, so in this, because all the sides are equal, so we get images in 1:1 ratio. That is, it is more accurate. Whereas in case of CT scan, as you can see here, X is equal to Y, but Z is not equal to these. So there will be distortion in this. So what happens is that in CT scan, the image will be less accurate as compared to CBCT. Now, this was theoretical. We will understand this with the help of different cases and different examples. Now, as you can see in this image, यहाँ पर एक swelling है on the palate. तो इस पैलेट पे ये जो स्वेलिंग है, इट कुड बी ड्यू टू मल्टीपल कॉजेस. Maybe it could be due to it could be due to teeth related origin, or it could be either due to a salivary gland uh, lesion, or it could be due to nasal cavity, or also there is maxillary sinus over here, so maybe it could be arising from the maxillary sinus. So there are different possibilities. So how do we rule out and how do we go about further treatment? So as you can see that this patient underwent CT scan. Now you can see that there is this mass lesion and there is erosion, but we can't see the teeth properly. So we don't know whether if it is an abscess and which is because of any of the teeth, maybe there is a crack or maybe the tooth is affected and because of which there is this swelling. So we don't know that. So again, this patient was referred to us for CBCT. Now just look at the teeth over here. The teeth are appearing like they're looking so nicely. You can exactly assess the status of the teeth. So after seeing the scan, we can say that it is not related to teeth. So basically, seeing the amount of destruction and the amount of erosion of bone, and it is also extending into the maxillary sinus, we came to a conclusion that it might be a case of malignancy. So in that situation, we will not be wasting time and understanding or considering this kind of diagnosis. We can directly refer the patient to higher center for treatment, because many people will want to remove the teeth, do extraction, and wait for the swelling to subside, and this will further delay the process of treatment, and the staging of cancer might change from first or grade 1 to stage 4. So that will not be a very good thing in terms of patient prognosis. So now you can compare CT with CBCT, and you can see the quality of the image that is here. So also difference between CBCT versus CT. In CBCT, there is lower radiation dose, rapid scan time, greater accuracy, reduced artifacts, multiplanar reformation, display modes unique to dentomaxillofacial imaging. That means in this, if you want, you can take only a scan of a single tooth or a quadrant or single jaw or both jaws or like TMJ. So we can choose here. It's not like in case of CT that you have to go for entire face scan, even if you want to see one particular tooth, and that also will not be seen clearly in CT scan. So the different clinical applications of CBCT include in case of endodontics, pathologies, orthodontics, implants, TMJ disorders, impactions, paranasal sinuses, nasal cavity, trauma, and ear. Now, question is CBCT really important? तो यहाँ पे हम लोग देख रहे हैं कि यहाँ implants लगे हुए हैं. So you can see that you can see this implant and this implant. Many people will think that this one is good, but these are not good. So, but when we see in sections, we can see that the implant in relation to 4-3 region is already perforating the lingual cortex. So this, which was looking good in the 2D picture, is actually not right. And here they have done nerve bypass. So here, as you could see that this implant is overlapping the nerve, but actually it's a case of nerve bypass. So that is why CBCT becomes important. Similarly, in this case, why I have put this, because many people they do implants, a case of single implant without doing CBCT, and so they just say कि हम ना RVG से कर लेते हैं, and so, then this happens. There is magnification in 2D images, so because of which you tend to over assess the bone, and then because you are not able to choose the right size of the implant, so this is how it goes into the nerve. So this patient was having paresthesia and pain and swelling. So ultimately, doctor had to remove the implant. Now here, similarly in this case, this implant looks good in 2D, but as you can see here that there is no bone on the palatal side. So it's a case of failed implant. Now another example, as you can see this cortical implant in 2D image, you can see that it appears to be in the bone between the nasal cavity and the maxillary sinus. But when we see in 3D, we can see that it is properly engaging into the nasal cavity. So let us talk about the role of CBCT in implant planning. So the different objectives of implant imaging include bone type, bone quality and dimensions, then to assess if there are any vital structures in the adjoining area, and also surgical prerequisites like grafting, whether grafting is required or whether you need patient specific implants, also to plan which type of surgery will be needed. So there are different phases: pre-prosthetic, surgical and interventional, and post-operative assessment. So the different anatomical considerations that are there in the pre-implant planning or phase one, that is, you can see either a bifid nerve canal or a wide incisive branch or knife edge ridges. In that case, we need subcrestal measurements, as you can see here. Then many people say कि anterior वाला जो bone होता है mandible में, ये this is the safe zone और यहाँ के लिए तो CBCT नहीं कराना होता है, हम आराम से इसमें लगा सकते हैं implant. But then what happens is that, as you can see, that there are sublingual vessels over here. So there is not sufficient bone to put implant in this region. So that's why we had to plan like this. But doctor wanted to actually place 3 implants. So we told him that it's not possible because of this thing. So what problem you will face here? So problem is that when there is consistent bleeding, so there might be damages on the branches of the sublingual artery which penetrate the lingual foramina. Also, when there is a lingual foramina larger than 1 millimeter in diameter on a pre-implantation CBCT, clinicians must be aware of the vessel damage. In order to prevent these complications and progress with a safe surgical procedure, a thorough radiographic examination before the surgery is indispensable. Now, as you can see here, you can see the wide incisive branch. So it's not possible to place implant in this region. Sometimes there are accessory mental foramen, which, although it's a rare anatomical variation, but we must be aware of such findings also. Then for post-operative assessment, in this case, you can see that this implant is fractured and also there is periapical infection in relation to this tooth. So the patient was having difficulty in eating food. So we had to replan. So we planned another implant over here, and then there was bone loss in relation to this implant also. So we planned like this so that again the patient can be rehabilitated. Then many a times the ridges are atrophic. So in that case, we can go for pterygoid implants. So as you can see, there's not enough bone in the posterior maxilla. So we have planned for pterygoid implants. And that's how we gave the 3D planning. And you can see the result. So this is how they place the pterygoid implant. So you can, without going for sinus lift procedures, whether direct or indirect, the pterygoid implant is a very good option. Then sometimes there is not enough bone in the pterygoid region also. So in that case, you can go ahead with these kind of zygomatic implants. So this was a case of cord zygoma. So that's how they place the implant. So we gave the dimensions like this, so that the doctor can decide the length of the implant. Now there is this question, as you can see on the screen, that there is this tooth and there is a huge lesion in the periradicular area. This patient he had undergone RCT and he was complaining of pain and swelling in this region. So many people would think that let's do a re-RCT, or sometimes people might think that immediately we can go for extraction or removal of the tooth. So in that case, how to decide or how to go about the treatment? So when we did CBCT, we can see that there is crack and fracture lines, as you can see here. So definitely the prognosis for this tooth is not very good. So you can simply extract without going for re-RCT, and extract and go ahead with the implant planning in this case. Now, this is a case of a 19-year-old male patient, and he underwent trauma while playing cricket. So in these cases, what would you want to do? As you can see that there is this fracture line here, then patient is having pain in these teeth. So many आप calcium खा लीजिए और ये ठीक हो जाएगा. Some people would want to do splinting. Some people would want to do RCT in these cases. But what is actually required, and the plan should be perfect. So in that case, when we did CBCT, we can see that there is a crack line over here in 4-1, but it is only involving the crown. Similarly, in 3-1, also we could see this faint crack line. So again, we can go ahead with RCT in these two teeth. 4-2 was normal, so we don't need to do anything with 4-2. And in 3-2, we can see that there is this very faint crack line. So even if we go for RCT in this case, it would be a failure. So you can plan for extraction of this tooth. Maybe if the patient wants immediately, then immediately. Otherwise, you can just inform him and wait for it. And maybe at a later date, if there is any infection, then you can go ahead with treatment. Or if the patient is having pain, then you can go ahead with extraction. So the role of CBCT in endodontics. Now this patient was having pain in these two teeth, and the doctor was very sure that he had done a very nice RCT, and he said that this is a psychiatric patient. So we went ahead with the CBCT, and what we found that in 1.5C there is a patent palatal canal, and also in 1.7 there is MB2 canal, which is also not obturated. So patient is not psychiatric. We have to assess, we have to consider all the possibilities. What was not visible in 2D is now very clearly visible in 3D. So that is the importance of doing CBCT. Then now you can see here that there's perforation in these teeth. Now this patient was complaining of pain in 3-7, and we couldn't see much on IOPA and also on the OPG. So when we did CBCT, we could see that there is a vertical root fracture, as you can see in these axial sections also. So finally, after struggling for like 3 months, when finally CBCT was done, and then the tooth was removed because of this diagnosis. After that, patient was fine. Otherwise, he was traveling to many doctors, and nobody could diagnose what's the real problem. Now, in this patient, he was complaining of sensitivity to hot and cold stimuli in relation to 1.7. Apparently, in 2D images, we couldn't see much. So, but when we did CBCT, we could see that there's a fracture line over here in the crown. So you can easily go ahead with RCT. Similarly, in case of this tooth, 2-2, there is a periapical pathology, and the doctor wanted to go for RCT. But when he was doing, he was not very sure about the root canal anatomy. Now, when we see here, you can see that there are these three orifices. Basically, there were three canals in this. So you can see what is the alignment of the canals. So you can easily locate the canals, and then you can assess the length of these canals. You can assess the working length, and you can proceed with the treatment. This premolar has 4 root canals. So we do find many canals in different teeth, and sometimes it really becomes difficult to assess clinically, and then CBCT becomes important in these cases. So these are the different, you can see the different canals in 4-5, and that's how, that's the course of the canal within the root, and that is the length of the canal, as you can see here. Then we get CBCT for C-shaped canal anatomy also in case of mandibular second molars. So you can see here, look at the proper C-shaped canal, and then how is the canal traversing within the root, the different orifices where they are bifurcating, or where they are merging together. So that you can assess with this. So this is how the canals were appearing, and we can assess the length. Then you can see that there is a calcified root canal, and then there is external root resorption over here. So patient was assessed, was referred to us for assessing the root canal anatomy. So with sometimes people want to go for guided endodontic access for calcified anterior teeth. So you can go for surgical guide preparation, and you can proceed with the RCT like this, especially in case of young patients and also in anterior region. Now, this tooth 1-2 is enlarged and there is a periapical pathology. And when we did CBCT, just see that the two teeth are fused together, and also there is this dense indenting over here. You can see in axial section that these canals are merging together. And also there is a dentoalveolar abscess, as you could see in the periapical region. Now, role of CBCT in assessment of pathologies, TMJ, impactions, paranasal sinuses, and salivary gland. So, as you can see here, that there is a multilocular lesion in the right posterior mandible. In the axial sections, you can see the nature of the lesion, how much there is cortical expansion, there is uh, erosion of the mandibular nerve canal. There's no evidence of calcification, but you can see some amount of septate formation. It could either be KCOT or meloblastoma or ABC or CGCG, different diagnoses we can consider. Then you just look at this left anterior maxilla. Just see the quality of bone. It's not looking very good. It appears to be a mixed lesion. Then look at these axial sections. Look at the nature of the bone over here. You can see how the quality of bone has been destroyed. So the differential diagnosis in this case include either odontogenic myxoma or odontogenic fibroma, ameloblastoma, CGCG, central intraosseous hemangioma, or osteogenic sarcoma, but it will have a speculated appearance. Now, this case, this patient was complaining of non-eruption of upper front teeth. So when we did CBCT, we can see that there are multiple teeth. There's a mass with multiple teeth-like structures. So it's a case of compound odontome. So because of this, these teeth are not able to erupt in the proper place. Now, this patient was complaining of swelling in the right posterior mandible region. So when we did OPG, we could see that there is some abnormality in this region, and it appeared that the bone over here is also not, it doesn't appear to be normal. So we advised CBCT. Now in CBCT, we can see that the lesion is extending till here, this part, but this one is more immature or radiolucent, and this part is more mature or radiopaque. So that means it's a mixed bilocular lesion. So the possibilities include either a ossifying fibroma or ameloblastic fibroma or odontogenic myxoma. And the biopsy features were consistent with that of fibroma. Now, this 5-year-old female patient was complaining of swelling and pus discharge from left side of face for 2 months. So you can see here the expansion of the mandibular body. Uh, this appears to be like a periosteal reaction. Then there is perforation over here. So it could either be osteomyelitis, and another differential to be considered is fibrous dysplasia. Now, in this case, you can see this 15-year-old male presented with facial asymmetry. So look at the ground glass appearance of the mandible and the expansion of the mandible in this region. Also, just look at the mandibular nerve canal over here. So we gave a diagnosis of fibrous dysplasia in this case. Now, this case is important. Why? Because patient was having some pain in the teeth over here, and doctor simply did extraction, and then she was complaining of a non-healing wound in this region after extraction of the teeth. So basically, what history he missed was that she was suffering from tuberculosis, and now she had developed tubercular osteomyelitis. So just look at the quality of bone, how bone has been destroyed. So here I want to say that history is also important before you directly jump into any kind of treatment. So take proper history, go with adequate scans, go with proper blood reports, and then go ahead with treatment. And also try to go for biopsies so that you get final diagnosis properly. And if there is any requirement of culture or anything or any blood test, please don't try to miss all those things, because that is also important. Now, this patient was complaining of fluid discharge from the upper right jaw region, and he gradually underwent extraction of the teeth from here. So he came to us for the scan, and then when we saw the incisive canal, the diameter was, it was measuring more than like 9 millimeter. It was at 9.2 into 9.5 into 12.2 millimeter in greatest dimensions. So this was actually a case of nasopalatine duct cyst, which was uh, the diagnosis was missed because of 2D imaging and he was suffering for 10 years, because an average incisive canal has a diameter of less than 6 millimeter, but here you can see that the incisive canal is enlarged. So this is another case of incisive canal cyst. This is significantly enlarged, and don't try to attempt extraction of the teeth thinking that it could be either a radicular cyst or something like that. First, go with the proper scanning and imaging so that you can decide with the treatment. Now, there is a 35-year-old male patient, and he was complaining of pain in lower right back jaw region and restricted mouth opening. And he was referred to us for CBCT of TMJ. But when we did TMJ CBCT, we could see that the TMJs, the condyles appear to be normal. So in that, and this patient went from clinic to clinic, clinic to clinic, for 6 months. So even when the patient visited to us, TMJs were normal, but we checked the patient and then we decided to go for a full mouth scan. So in that, we could see, can you see the amount of erosion in this area? There is erosion of the posterior border of the right maxillary, posterior wall of the right maxillary sinus. And there is a mass over here with partial compromise of the airway, as you can see here. Similarly, this mass is over here, as you can see in this region. See here. You can see here. And there is erosion of the ramus also in this region because of the mass. So there's a large hypodense lobulated mass lesion involving the right retromolar trigone and the this vestibule area. So basically, it was a case of malignancy and causing a partial compromise of the regional airway, and patient was referred to higher center for further management. Now, this patient, she was complaining of swelling in right side of palate. So again, we can think of different types of differential diagnosis as we discussed earlier. So when on CBCT, we can see that it appears to be a benign lesion and not related to the tooth. And also there's no significant erosion of bone in this area. So we gave a diagnosis of minor salivary gland tumor and a histopathologic diagnosis of pleomorphic adenoma of minor salivary gland was given. Now, this patient, she was complaining of swelling in the right posterior mandible for 2.5 years. Now, when we see this, we can see that that the right mandibular nerve canal is widened and it has a tortuous course as compared to on the left side. So we can see, as you can see also on the axial sections, that the right mandibular nerve canal is widened. So it could either be a neural or a vascular lesion. So plan your treatment accordingly. This patient was complaining of pain in the neck for 2 years and the teeth appeared to be apparently normal. But we can see that the styloid processes are elongated. So on CBCT, we could see that the styloid is almost double the size. So we considered it to be a case of Eagle syndrome and patient underwent surgery and after that she was fine. CBCT is also helpful in assessment of impacted teeth, as you can see here, to see the orientation and its relation to the nerve canal and how to plan your treatment. So as you can see in this axial section, that the crown is impinging on the lingual cortex and the root is impinging on the buccal cortex. So also its relationship with the nerve, you can assess like this. So you can see whether it is approximating the nerve or not. So it is very close to the foramen. So you have to be very, sure, like you can see in this section, uh, you have to be very careful when you are removing the tooth. Okay, so this is the 3D image of the same case, the impacted premolar. Now, many a times we get referrals for assessment of the proximity of nerve to the impacted third molars, as you can see here. So in these sections, you can see that the nerve is going lingual to the tooth and it is indenting the tooth on both the sides. So how the crown is aligned, how the root is aligned, the root is indenting on the buccal cortex and nerve is going from between. So it's like that you can decide from where to, whether you want to do section of the tooth or what should be your approach, whether it should be buccal or lingual. So like that. So in that case, CBCT becomes helpful and important. So here you can see how the nerve is positioned and what's the relation to these teeth. So that you can see over here, just relation with the roots. Now, this patient was complaining of swelling in the left midface for 6 months. So we can see that there's a large radiolucent lesion over here, and there appears to be a tooth-like structure in the left maxillary sinus. Now, when we went for CBCT, we could see that there is an impacted tooth, but it is located in the posterior part of the left nasal cavity. It is located somewhere here. So if you think that इजी सा केस है, मैक्सिलरी साइनस में दिख रहा है, बस फटाफट अप्रोच करेंगे, निकाल लेंगे, तो ऐसा पॉसिबल है कि यू माइट नॉट बी एबल टू इवन ट्रेस द टूथ because it is not located in the sinus, it is located in the nasal cavity, and that too in the posterior part. Just look at its location, and then it is surrounded by this huge lesion, so which was appearing at some other location in 2D image. So CBCT is important. It appears to be a case of dentigerous cyst. Then assessment of position of supernumerary teeth associated with dentigerous cyst. You can see how these teeth are inverted and impacted and surrounded by a well-defined radiolucent lesion. Now, this is a case of multiple dentigerous cysts in relation to 1/8, 3/8, and 4/8. So you can properly assess what is the size of the lesion and and the location of the tooth and your surgical approach and planning. So this patient, 17-year-old female, complained of pus discharge from right maxilla for 6 months, and there was a history of extraction 6 months back. As you can see that here, that the teeth are missing, but you can't see the bone alveolar process properly. In fact, it is communicating with the sinus, and then you can see that there is a radiolucent lesion which is surrounded by a mucosal thickening. So you can see that it's a case of oroantral fistula with right maxillary antral pseudocyst with associated mild mucosal thickening along the pseudocyst. Now, in this case, patient is complaining of escape of fluid into the nose, and also you can see these lesions on the foot and on hand. So when we did CBCT, we could see that there is erosion of the bone over here. So this is a oronasal communication, and it could be secondary to either leprosy or some mucocutaneous lesion, deep fungal infection, or dermatitis herpetiformis. Also, you can see here, see the communication in this region over here. Then this 53-year-old male patient complains of mobile teeth in upper jaw associated with bleeding. He was a known case of diabetes mellitus and had COVID infection in April 2021. So he was complaining of mobility of teeth. He underwent extraction, but he was not fine. So patient was referred to us for CBCT. Then you can see, just look at the quality of bone, look at the amount of erosion that you can see, which is involving the alveolar process. Look at the maxillary sinus, there is erosion. Also in these subsequent coronal sections, you can see the amount of erosion and destruction over here on all these sections you can see. So we were considering a diagnosis of mucormycosis, and histopathologically it came out to be mucormycosis. Then patient was treated at KGMC. Now, this case, 32-year-old male patient complains of pain in right preauricular region for 2 years, and history of trauma and past surgical correction was there. you can see that there is fracture of the anterior wall of the external auditory meatus, and there is bony remodeling. Also see the condyle. There is bony remodeling in this condylar head also. So there are changes of right TMJ arthritis with post-traumatic sequelae with associated bony remodeling. Now, in this case, there is fracture of the right mandibular condyle with partial minimal union and callus formation was there. As you can see that there is a callus formation, there is fibrous ankylosis, and this is secondary to dislocation of the temporomandibular joint. Now, another case, this patient was complaining of restricted mouth opening. When we did CBCT, we could see that there is uh, ankylosis of the tooth. Also, ankylosis of the condyle to the temporal bone. Patient was actually suffering from psoriasis, and it was a case of psoriatic arthritis with bony ankylosis. Now, this 80-year-old male patient was complaining of pain in left preauricular region. So, what do we see here? We can see the flattening of the articular eminence, flattening of the articulating surface of the condylar head. Then there are subchondral pseudocysts that we can see, and there is a small osteophyte that is present. So, these are all degenerative changes that we see in old age patients. So that also becomes important to assess. Now, this is a 30-year-old female patient. She was not able to open her mouth for past 8-9 months. And when we did CBCT, इसने भी CT scan कराया था, उसमें normal report दिया था. Then what happened here, when we did CBCT, we could see such a big mass over here. So a diagnosis of osteochondroma was given. Later on, patient underwent surgery and this mass was removed. And then she is fine now. Now, this patient was complaining of facial asymmetry. So, on this OPG, we don't see any lesion over here as such, but this left condyle was slightly elongated. So, basically, it was a case of condylar hyperplasia. So, you can see the right condyle and see the left condyle. So, it is elongated. Now, this is a case of coronoid hyperplasia, and there is TMJ ankylosis. So it is when patients come to you with restricted mouth opening, you don't just have to focus on this condyle or TMJ region कि पेशेंट को बता दिया कि ये TMJ है, यहाँ पे ankylosis है, इसको सर्जरी करके ठीक कर देंगे. You have to, many people because don't think about this thing also. So you have to remove this also so that this restriction it becomes clear or it opens down. Now, this is another case of ankylosis of condyle with coronoid hyperplasia. You can see in this section also. And see, there is bony ankylosis over here. This patient was complaining of pain. He underwent extraction of this tooth, but he had pain for 11 months. So, and clinically everything appeared fine, but when we did CBCT, we could see that there is no healing over here. So basically, it's a case of delayed healing because of which patient was having pain continuously. Now, sometimes we get cases like this. So there are different tiers of multiple impacted supernumerary teeth. So for complete assessment of that, you can go for CBCT scan. Now, in this case, you can see that there's a huge mass over here in the right maxilla. So basically, and in the CBCT, we can see that there is this mass which is surrounded by a peripheral radiolucent rim. So, and there is associated with impacted tooth. It might be a case of central ossifying fibroma. Now, another similar case of ossifying fibroma surrounded by a radiolucent rim in a 8-year-old child. So this is the OPG of the same patient. CBCT is also helpful in assessment of trauma in case of teeth fracture, fracture of the mandible, ramus fracture, subcondylar fracture, like that. Here you can see fractured anterolateral wall of the right maxillary sinus. You can see on 3D also. See on these subsequent sections, coronal, sagittal, and axial. We have seen cases of hyperplasia of the condyle. Now, this is a case of hypoplastic left mandibular condyle and coronoid process and ramus as compared to the right side. As you can see, these images, this is normal and this is not normal. So patient was having facial asymmetry. Now, for nasal cavity, this patient was complaining of bleeding from the nose for 5 6 months and also post nasal discharge. So we could see that there is some radiopacity over here, maybe a tooth-like structure, but the teeth over here are all normal in the number. We don't see any missing teeth over here. So on CBCT, we could see that this might be a supernumerary tooth which is displaced into the nasal cavity and it is surrounded by mucosal thickening, which might be leading to inflammation and also for post nasal drip. So with these sections, you can easily plan your surgery and get this tooth removed, and the patient will be fine. Now, this is a case of a 65-year-old male patient with swelling on right side of face associated with blurring of vision in relation to right eye, complaints of fluid discharge in the oral cavity. So look at this expansile large lesion involving the right maxilla and also right orbit is complete. The walls are completely lost. You can't see the lateral wall and the orbital floor, and the complete loss of maxillary sinus and also the lateral wall of the right nasal cavity. It also involves the right maxillary alveolar process. So basically, it's a case of malignancy again. Now, this case is very special because in this, there is a gingival swelling, gingival hyperplasia was there, and the doctor asked the thickness of the tissue that is covering the teeth so that he can plan his surgery because here he can't see. So, in these sections, we could measure what was the thickness of the soft tissue that was covering the teeth so that he could easily shave it off. He knows how much to remove, and the patient was then fine after the surgery. Now, sometimes patient complain of pain, so we think that there is problem with the TMJ, but there can be problem with the ear also. So this is a case of otitis media, and thus the condyles were fine, but here you can see that there is infection in the ear cavity. So this should also be kept in mind. If in that case, you should refer the patient to ENT. This is a normal ear, and here a normal ear cavity, and in this you can see that the ear cavity is normal. Now, this is a case of malignancy. Patient was complaining of mobile teeth. Just see the amount of bone loss that is over there, and the teeth are bereft of bone support. Now, this is a case of radicular cyst associated with a crack, and so there is the tooth is cracked. You can see the crack line here also, and then associated with a huge periapical lesion. So it's a radicular cyst case. Now, these are the different periapical radiopacities or lesions that you can see. This is a cementosseous dysplasia, condensing osteitis where tooth is affected, then idiopathic osteosclerosis. The tooth appears normal. In hypercementosis, you can see this, and in cementoblastoma, just appreciate the difference in this. So comparison of CBCT with other modalities. OPG is a 2D scan. It is good for screening but limited detail. CT is excellent for soft tissue but it gives higher radiation dose. MRI is best for soft tissue, especially for disc and nerves. And CBCT is best for hard tissue, also for dental tissues, and it gives lower dose. So the conclusion is that CBCT is an emerging CT technology which has potential applications for imaging of high contrast structures in the head and neck region. Its advantage of MPR and 3D reconstruction enables us not only to diagnose or assess the pathology precisely, but also plan the treatment more effectively. So, thank you so much. Thank you for patient hearing. If there is any doubt, please let me know.
Yes, Dr. Deepika, it was a very interesting and very knowledgeable, very informative talk, and a lot of cases you have shown. So it gives definitely a good impact to our participants. We have a lot of questions by the audience. So
Okay.
shall I take the questions, Dr.
Yes,
Deepika?
yes.
So the first one is from a final year BDA student, Ria
Mhm.
Sharma.
Okay.
She asks that in cases of deep caries with
Mm.
suspected pulpal involvement, when
Mm.
should we prefer CBCT over IOPA?
See, that's not necessary because what happens is that if you see that there is pulp involvement, so you want to go for RCT. Now we have to see that whether, if you want to assess how many canals are there, if there is a endoperio lesion is there or not, if there is any periapical infection or not. So sometimes it is not necessary that in all cases you have to go for CBCT. CBCT is useful when you want to see if there are extra canals, if you are missing some canal, if there is perforation or ledge, if there are cracks or fractures. So in that cases you can go for CBCT, or if it's a case of re-RCT, then you should definitely go for CBCT. It's not necessary that for every patient, if you will tell that go for CBCT. However, in metropolitan cities, they are now getting into this practice that every patient should go for CBCT. It depends on where you are practicing.
Right. The next question is by Dr. Aman Verma from Lucknow. As per your experience, ma'am, what are the common mistakes beginners make while interpreting CBCT scans?
First of all, you should know that how many different bodily planes are there. Then many times I have seen people, even I have seen maxillofacial radiologists, new ones, that they give wrong sections for different cases. For example, in case of endo, they will give you cross sections, and these cross sections are required for implant. So all these are all common mistakes. And after that, many a times uh, you will see that the anatomy is missed, and then the periapical region, the bone, sometimes the bone is normal, but I have seen many reports in which people are writing that there is a periapical infection. So that is a blunder. And I will say that you should always consult with your radiologist, that what he or she has seen in the CBCT images directly. Don't just jump into your interpretation. You please share your clinical findings, or description, whatever is the patient's problem, with the radiologist, so that you can come to a proper conclusion and you can formulate a good treatment plan.
Right, very right. The another question is by Dr. Neha Patel from Ahmedabad. How reliable is CBCT in detecting vertical root fractures compared to conventional radiographs?
See, in conventional radiographs, most, like 99% of times, you will not be able to assess cracks or fractures until and unless the fracture is very big, only then that you can see clinically also. Then there's no requirement for CBCT. But there are very minor crack lines which even it becomes difficult on CBCT to assess. So sometimes in those cases, but patient will complain of pain. So in those cases, what we do is that we take at least 2 scans minimum, so that we can cross check. So to see all those crack lines and what is the extent of the line. So if there is any case in which you suspect a crack or a fracture, you should definitely go for CBCT and assess with the vitality test and CBCT.
Right. So the clinical part is also important.
Rely on your IOP.
Yes.
Unstable.
Yeah, yeah. It's okay. Now again, it has become now it's. So the another question is by final year student from Hyderabad, Karthik Reddy. Can CBCT be routinely used for orthodontic treatment planning, or should it be case specific?
In orthodontic treatment planning, for I'm sorry, there is some background noise here. Am I
Can I
audible?
repeat? Yeah, yeah, you are audible. Can I repeat the question? You are audible, Dr. Deepika.
Yeah, please. Okay, please repeat.
Yeah, so the question is, can CBCT be routinely used for orthodontic treatment planning, or should it be case specific?
It is case specific actually, because if there are impacted canines, impacted premolars, impacted molars, if you want to see the whether you want, like, what is the orientation of the impacted tooth, whether you want to, will you be able to extract it, or if you can bring it down orthodontically. So in that case, CBCT is very helpful. And also what the impacted tooth is causing to the adjacent teeth, whether it is causing resorption of the teeth, whether it is displacing the teeth. And also if you try to bring the impacted canine down, so in that case what will happen, while bringing it down in the process, will it affect the adjoining teeth? So all those considerations become very important. So then you should definitely go for CBCT. Otherwise, for normal cases, it's not very required.
Okay. The next question is by Dr. Simran Kaur from Chandigarh. As per your clinical experience, how do you decide the field of view while prescribing CBCT?
That depends on the patient complaint. For example, if there is a big lesion which is involving entire jaw, then we'll take for a single jaw. If it is involving one or two teeth, then we'll go for a quadrant scan. So it depends. And many a times, what happens is that when the patient visits the doctor, the patient will tell that I am having pain in 3/6 region, for example. So, but what happens is that when the patient comes to us, we will ask for if you have OPG or not, and or if there is a swelling, what is the extent. So sometimes when you see clinically, it appears to be small, but when the patient comes to us, it actually there is a big lesion. So in that case, FOVs change. So it is a very good practice to either have OPG with you, so that with that you can relate how much area you want to cover.
Right. Another question is by Dr. Rahul Das from Kolkata. What precautions should we take regarding radiation exposure, especially in younger patients?
There is very less radiation exposure in CBCT, so don't worry about it. It's like equivalent to धूप में जाना. Or in fact, we also say that कि एक बार सीटी स्कैन कराए और 50-60 बार सीबीसीटी कराए, दैट इज इक्विवेलेंट. सो इतना डिफरेंस होता है एक्सपोजर में. So don't worry about that. But there's one thing I would want to add to this, कि जब बच्चों का स्कैन ले रहे हैं ना, उस सिचुएशन में या किसी का भी ले रहे हैं, तो यू शुड पहले से पेशेंट को यू शुड टेल द पेशेंट कि डोंट मूव, स्टे स्टेबल, सो दैट यू गेट प्रॉपर डायग्नोस्टिक स्कैन एट वन गो. तो उससे फिर प्रॉब्लम नहीं होती. अगर पेशेंट मूवमेंट कर रहा है, स्कैन ही खराब हो जाएगा, तो फिर रिपीट करना पड़ेगा. सो दैट्स नॉट एडवाइजेबल. गिव प्रॉपर
Right.
इंस्ट्रक्शंस टू द पेशेंट.
Very right. Very practical approach also. The last
Yes.
question is by Dr. Pooja Nair from Kochi, Kerala. In implant planning, is CBCT always mandatory or can we rely on conventional imaging in some cases? I think,
I
uh,
will I will not suggest. You never know what is going to happen, because many a times we see that the length of the bone is very good, but when we go for CBCT, there is no, like, width is only not there, or it's a knife edge ridge, or we can see, like I already discussed about the wide incisive canals, and then the location of the mandibular nerve, and then about the sinuses. So I don't advise it, because I have seen failing cases. That's why.
so Swastika,
Yes, sir.
uh, you want to say something or shall I conclude with vote of thanks?
Sir, at first you can go ahead with a word of thanks and then I will be concluding, sir.
Okay, fine. So, I sincerely thank our esteemed speaker, Dr. Deepika Keshri, for her valuable and evidence-based session on CBCT, and gratitude to Indian Dental Association, IDA, Hisar branch, DentalNet, and all the participants for making this program a great success. We'll look forward to seeing you again in our next program on 3rd May, which will be on prosthodontic related topic. And I request everyone to kindly subscribe to the IDA Hisar channel for regular educational content for dental professionals. Thank you so much. And I want to again say that Dr. Deepika, it was we got a very good response from Pan India. Almost
Thank
500
you.
registrations were there.
Wow. Thank you.
I think we have received one more question from
Okay.
Dr. Manoj Kukreja. Whether
Okay.
CBCT is safe in pregnancy? Can you like throw some light on this part also? CBCT
We
in
don't
pregnancy.
recommend. We see. Ideally, we don't recommend, but it is not unsafe. You can use a lead apron and you can go ahead with the scan if it is
Your
required. That's not a very big
I
deal,
think
because
you
anyways,
can
radiation is not much of a problem.
You can repeat your part. Actually, we lost the connection. Dr. Deepika?
Okay, okay. I'm saying that I don't do it regularly, but just in case, if it is required, you can go ahead with a lead apron and take the scan. And although also the radiation exposure is very low, so you don't have to worry about it. But try not to do it. But if it is required, you can go ahead with proper safety techniques.
Very right. So I hope this answers all the queries. A lot of queries were there. So over to you, Dr. Swastika.
So it's just Swastika, sir. So thank you so much to all the interviews present here. Dentalent is really glad to have all these brilliant people together in this session today, and I really hope that you all had a seamless experience. So with everyone's permission, we are now concluding the session in here for today and looking forward to have you again, sir.
Thank you.
Thank you so much. Thank you so much. Have a great day, sir.
Thank you, Dr. Deepika. Thank you, Swastika. Thank you,
Thank you.
Dr. Pankaj Singhal.
Thank you so
Thank
much,
you
sir.
all the participants. Okay. See you again.